lovely. Thank you, Phil. And yeah, thank you for asking me along this afternoon. It's been a great day, really. So thanks to you, really, for putting this on as well, Phil. I do appreciate it, and for all the other speakers, it's been great. So yeah, thank you. So yeah, I'm James Holloway. I'm the Group Head of Safeguarding with Elysium Healthcare. We're a national provider who have services in four main divisions: mental health services, learning disability and autism, neurological services, and a CAMS division. And we are nationwide, and we've got a few services in Wales as well. So that's just a little bit about Elysium. I appreciate there's people on the call here from a whole range of services. So if you don't know who we are, that's a little bit about what we provide. And this afternoon, just going to be talking about learning from a domestic homicide incident that happened to somebody who was an inpatient at an Elysium health service. Okay, that's it. Thank you, Phil. So I suppose the first thing to say is really that this is an ongoing case. There's been no final report written about this domestic homicide review. It's still going through process. We've had several panel meetings about it, and we're at getting towards the final stage, but there's nothing out there in the public domain as yet, which is why I won't be giving any specific details to the situation and to the case involved, just some very basics really. And essentially, I think this learning will apply regardless of sort of context really anyway. And a fair part of it, unfortunately, is this is learning that you probably will have heard before. And these are the things that we often come up with in these sorts of reviews, but it's just really highlighting the fact that these things are ongoing. They're still out there. But as I said, I'm not going to give specific details of who, what, where, when, that type of thing. The basic background is there. It was a 31-year-old lady who had a history of mental health problems. She had been in and out of services, in and out of inpatient units, slightly chaotic at times, so was receiving support, engaging well, then disengaging and not known to services for some time, and then re-presenting. So somebody who was dipping in and out of services really, but that's not to say that the problems were dipping in and out. The mental health issues that she was living with were always there. It just was dependent on her engagement with services. Just prior to her coming into an Elysium service, she was under the care of the home treatment service, and she had been for a couple of weeks or so before it was realised that we needed to admit. It was an out-of-area admission. There were no local beds, available for this lady. It wasn't hundreds and hundreds of miles away, but it was certainly across at least a couple of county boundaries. So not even next door county we're talking about here. So it was slightly out of area from that point of view. It was an informal admission, no mental health framework around this admission. The lady had consented to admission, felt that she needed to be admitted, and agreed to the admission at the time. She had been living on and off with an abusive partner, and this was a history of both physical and mental abuse that she'd been subjected to, so coercion, control, as well as physical abuse as well. She had a son who was living with her parents, who again weren't local to her, so there were some geographical challenges there for her to actually have contact with her son. But that was considered later on as protective factor, as we'll pick up later on. But actually, at the time that she came into hospital, there were very few protective factors really in her home life. Okay, Phil, thank you. Okay. So just one of the sort of questions to pick up on really is, why are we going through a domestic homicide process when somebody has ended their life by suicide? And I think that's probably that was one of the first sort of questions really that people were highlighting when the panel came together. But actually, as we can see from the standing together guidance, which specifically states that, for example, if it emerges that there was coercive, controlling behaviour in the relationship, a review should be undertaken. So that's very much the case in this situation, really, that we've got exactly that. There was controlling coercive behavior in the relationship. The the um the suicide was looked into that context, although it wasn't a specific physical homicide in terms of the abusive partner was no way physically responsible at the time, but all of the coercion and control very much was a huge factor in the suicide and the ending of her life. And when we look at risk factors for suicides and domestic homicide suicides, unfortunately, this case pretty much ticked all of the main boxes of um, being with somebody who's had prior abuse issues, so a perpetrator of prior abuse, mental health issues, substance misuse, alcohol misuse, and obviously the coercive control. So the very factors leading up to this were all there. And again, hindsight is wonderful, and we can all see these afterwards. And that is what part of the review will be bringing out, that there was this coercive controlling behaviour, which is why the review is taking place, even for a suicide. Thank you, Phil. so, so part of the admission, it was in May of 2021, and I think it's worth considering the COVID implications. And I know that at the time, memory serves, we weren't in any formal lockdown, or there weren't any formal restrictions at that time. We certainly were in a position where we were just getting used to the idea of what COVID did in terms of visiting, contact with families, all of it was a whole new way of working. So it's all of this needs to be taken in with that context, really. I don't think we can look at it in isolation. So it was an informal admission. There was no mental health act required. It was admission was discussed with the patient, and it was something that she agreed to. So therefore, didn't meet any requirement, wasn't liable to be detained. There was no bed available locally. So despite best efforts to try and find somewhere more locally to both her and her parents, where her son was. So trying to, fit in all of these geographies, it just wasn't possible at that time. So it ended up in being an out of area placement, as I said, not hundreds of miles away, but certainly out of area, which immediately presents problems of um, thresholds, consent, understanding local geographies, understanding local teams, understanding local language, really, about what we excuse me, about what we call teams in different areas that may well be doing the same thing. It was a relatively short admission. It was only a 7-day admission. She was only in hospital for a week, which again has its own challenges. Excuse me, I'll take some water. That excuse me, that creates its own challenges in terms of getting to know your patient, understanding your patient fully, for doctors to complete ward rounds, for full assessments to have taken place within a ward, to actually really get to know and understand not just your patient's presentation, but support networks outside of hospital, and making those links with community services, and the networks that are needed to be in place upon discharge. Now, the risk assessment when she came into hospital had an overall risk rating of high. It was recorded down, and the three main elements of that risk assessment on admission, we've got the suicide risk, which was rated medium, deliberate self-harm as high, and vulnerability from self-reported domestic abuse was medium. Now, that's interesting in itself, in as much as she came in and used, was reporting a degree of domestic abuse, even if it was, wasn't considered a high risk, the very fact that it was still there. And so that was graded overall as high. Now, the risk assessment at discharge had all of those three elements the same. we had a medium risk of suicide, a high risk of deliberate self-harm, and a medium risk of a medium risk of self-reported domestic abuse, but an overall risk score of low. So Phil, if you go to the next slide, please, it just goes on there in a bit more detail. So as I said, it was really only a week, so only 7 days later, that the clinical team are still assessing individually all of those elements the same. But overall, we're talking about the fact that somebody is now presenting with an overall low risk. And one of the quotes that sort of taken out from interviews and reports with staffing team around the crisis team were aware of her intention to return home where the partner resides. We now know that the partner, there was a history of domestic abuse there, but she was aware, the crisis team were aware of her intention to return. Staff have also spoken to her regarding return home, and she reports feeling safe and happy to go home and has the capacity to make this decision. So almost the entire risk assessment shifted from high to low based on the fact that she reported being safe and happy to go home and has the capacity to make this decision. Now, obviously, it's really important that we understand and we put our service users, our patients' views first and foremost, and we need to be fully aware of that and respond to everything that the service users tell us. And we're here to respect their views and their wishes. I think it's been mentioned a couple of times in other presentations before, even today, the idea of professional curiosity. And I think it was our first speaker this morning spoke of not even professional curiosity, but human curiosity. And I think there's an element here, there's a gap here, there's an opportunity for learning here, to really unpick this statement, really, that she reports feeling safe and happy to go home and has capacity to make this decision. Now, we don't know the conversations that went on between her and her partner around going home. There's a lot there that we don't know and we don't understand around her, how safe and how happy she actually was. If she's telling us that she's safe and happy, are we just taking that on face value? Are we digging into that a bit more? Are we actually unpicking what that means, what she's going to be doing when she's back at home? All of those elements there, really. But in terms of the risk assessment, as I say, clinically, from an outsider, we're just looking at the same levels of risk, but overall, we're grading the presentation as low from high, just based on that one. And that was the only evidence that I could find, really, to say that why we would be changing that risk score from a high to a low. Okay, Phil, thank you. So the discharge came, as I said, it was only after 7 days. So it was a very short admission. It's an acute stay hospital. So in fairness, the service themselves are used to the fact that people do come and go. They get admitted and discharged within 7 days. That in itself isn't unusual. Obviously, that presents its own challenges, which the service will be used to and will be working with all the time. So that in itself wasn't unusual, although it is challenging. There was, as I said, she had denied any suicidal thoughts of self-harm, and as we've just previously noted, she stated that she was happy to go home. She'd been in contact with her partner and her son. These were all considered to be protective factors for her. The fact that she had that contact with her son, and was reportedly looking forward to going to see him as well, although not living with him, but certainly being able to have that actual contact with him. So these were all considered to be protective factors. There was some liaison with the community team. And as I mentioned earlier, this is where the challenges come around understanding local services. What would have been called a home treatment team, that had a different name for it in the community team that she was going to. So messages from the hospital side, which were understood to be going through to the right people, weren't actually reaching the right people within the community services because of the way that the teams are set up. And if you work in that area, then you're probably going to understand how you get through to the right people. There was no formal discharge planning meeting, which involved the patient, the community resolution home treatment team, her partner, family, ward doctor. It was a very, ultimately, it was a very rushed discharge. And part of that would have been the fact that the service, the hospital, were aware that this was a patient who was informal, wasn't liable to be detained, wasn't presenting in a way that meant that she would be detained under the Mental Health Act. No legal framework in which to keep her within the hospital. So the discharge planning was very rushed. And although conversations were had and liaisons were made and messages were passed on, there was no actual gathering of everybody, either on a call, a conference call, a Teams call, or certainly not in person meeting to actually sit down, work out where she was going, who was going to do what, who was going to follow up in what way, and when they were going to do it. There was a plan for the home treatment team to make contact within 48 hours of discharge. That was unfortunately about as much of a plan as there was at the time that she left hospital. And then unfortunately, as it says, she was found hanging at home by her partner 2 days after discharge. So she hadn't been seen by the crisis team within that 48 hours. I mean, I guess 48 hours and or 2 days, it was within the time scale. So unfortunately pronounced deceased at the scene when the police and the ambulance arrived. So things that may ordinarily have been happening if in different circumstances, if the patient was within county, had it been more planned, a planned admission coming in for 7 days, everyone knows when the discharge was going to happen, who was going to be involved, all of those things which we would ordinarily get in a discharge, unfortunately, didn't happen on this occasion. Phil, thank you. So, as I said earlier on, really, unfortunately, lots of these learning outcomes will be familiar because they come up so often, unfortunately, in lots of these learning outcome reviews, domestic homicide reviews, safeguarding adult reviews. There's often about joined up working and communication. I said there were some additional challenges around this particular case. We've got challenges of the legal framework. She wasn't detained. There was no legal framework in which the hospital could keep her within hospital. She had told the hospital that she wanted to be discharged and she wanted to be discharged that day. Risk assessments would have been completed. We ended up with an overall risk assessment of being at low risk. Phone calls were made to out of area teams, messages were passed. There's an assumption that it gets through to the right people, but unfortunately there's no guarantee that you are talking to the person who's actually going to be following up in the community. So there was a lack of understanding of the out of area team process and who would be doing the follow-up when it came to it. Due to, again, the short nature of the admission and the family network as was with the abusive partner, parents living away, starting living with parents away, it became very difficult to establish who was the family network, who were the family supports, where we needed to go for that, who else would have going to be involved at the point of discharge in terms of support, not just professionally from the community team, but also just in the informal supports and who that network was. There was no way of actually establishing that, or it was never clarified during the admission. As I say, it was a short admission and something that an acute service are used to managing, but just with all these other complications on top, it became a challenge. Communication really between services, communication within the service itself, between ward staff, ward doctors, nursing staff within that particular ward, sharing information about the fact that she's wanting to be discharged, she's saying she wants to be discharged, getting all of those processes in place to make the discharge happen. So throughout there were issues around communication. So processes and systems around communication is certainly something that would be a learning outcome here. Joined up working between agencies, again, this is something that we would have picked up probably, as I said, in countless adult reviews. The fact that communication and joined up working needs to improve. There was a lack of discharge planning in terms of getting everybody around the table. There was an assumption that everybody thought they knew what they were doing, but not necessarily they knew what everybody else was doing and couldn't confidently say who was responsible for what part. And then the follow-up plans, what was happening afterwards from our point of view, from the hospital's point of view, it was a case of almost once she'd left the premises, gone out of the hospital, gone back, we weren't involved at that point in terms of knowing what was happening, weren't consulted about what was happening, weren't involved in any of that community follow-up. And again, that comes down, I think, to the fact that there's the out of area complication. I think we would have been much more involved if it was within area placement. And I think that that's just down to understanding your networks, your local systems, and just having that awareness of who to speak to and knowing who's involved. But the service weren't involved at all in anything to do as soon as she left the service. So I said they're not new learning outcomes, unfortunately. That's probably the saddest thing about this, that we're not suggesting we need to do anything radically new. We just need to make sure that we are doing the things that people have said for many times. We've got to get these things improved in terms of the communication and the joined up working between agencies. I think that's me done, Phil, but there may well be another slide. It's a thank you. So thank you all for your time. Thank you for sticking around. I suspect that you may well just be here for the headline act, Kenny Gibson, but thank you very much anyway for sitting through the presentation. I don't know if there's any comments. I've not been able to look at comments, questions as well as slides.
Oh, James, I mean, you're getting lots and lots of kind of emojis coming up from the chat and people commenting on how interesting it's been. And a lot of the challenges you reflected there are challenges that I imagine a number of the other providers kind of joining today will have experienced. So whilst it's yet to be published, I think it's a thank you from me and, judging by the comments, everybody else, for sharing that. There was one question just before we bring Kenny in, and Tracy, who works in the MOD, has asked about whether inherent jurisdiction was considered due to the coercion. Just wondering, considering the short kind of nature of the contact, and whether you even had time to explore that, or whether you're aware of any other agencies exploring that.
The short answer is that I'm not aware, Phil, of that being considered. That's possibly going to come out through the whole process. Who did you say asked that? I can't see that question, because I can certainly respond outside of this call if that's...
Yeah, of course. So it's in the Q&A function, and it's
yeah.
Tracy, who's a member of the forum, so we can pick it up outside as well.
Absolutely, I can certainly look into that. It's not certainly anything that I'm aware of, but I can find out.
That's brilliant. Thank you so much, James. And again, thank you on behalf of everyone. Lots of comments on how interesting the talk was.